this video we'll discuss about hypothyroidism. So basically in hyper it was increased levels of thyroid hormone. So in this it will be low levels of thyroid hormones, the circulating thyroid hormones. It occurs mainly in females. Now, what is goitrous hypothyroidism? It is basically hypothyroidism with an enlarged thyroid gland. Then there comes one more type, which is the subclinical hypothyroidism. Now, in this, what we see is there is a symptomatic condition in which the thyroid hormones are low but TSH is high. Okay, now coming on to the causes. First of all, the primary hypothyroidism, it is an autoimmune disorder. Okay, this occurs basically due to the destruction of the thyroid follicles due to an autoimmune process. Thyroid follicles due to autoimmune process. Now coming on to the causes, the primary causes and the secondary causes. In the primary causes, what we see is, first of all, it can be idiopathic. Then goitrous. In goitrous, we have deficiency of iodine, Hashimoto's disease, drug-induced, then dysharmogenesis, then we have post-ablative, basically after therapy of radiotherapy or after surgery. Then we can have transient hypothyroidism, which is basically due to physiological conditions like pregnancy. Also, then it can be maternally transmitted. Then iatrogenic. Now coming on to the secondary causes, as I told before, there are certain rare causes. So hypothalamic disease like trauma, tear, or due to pituitary, hypopituitarism or Sheehan's syndrome. Now coming on to the clinical features. In clinical features, as I told before, since we have hypo, so that means it will be decreased. So there we will think about the opposite, that is the weight that will be increased. Now coming on to the clinical features, first of all we see that there is dry skin. It is basically toad-like. Then there are sparse hair, very less hair, alopecia, non-pitting edema, vitiligo. Then in neuromuscular, we have aches and pain, delayed relaxation, muscle stiffness, carpopedal syndrome. Then reproductive may mention the same as we mentioned in hyper. Then in CVS, what we see is there is a decreased heart rate. Okay, so there is hypertension, xanthelasma is also there. Then pericardial effusion, then precipitation of angina. GIT, we have constipation, dynamic ileus. Now coming on to the investigation. In investigation, what you'll see is T3 and T4 will be decreased, TSH will be increased. Okay, now this TSH will be increased only in the primary hypothyroidism, not in the secondary hypothyroidism. Then we see that the TPO is also present. So also the high, there is cholesterol level is high, which was low in hyperthyroidism. Then in ECG, what you see is bradycardia. There you saw tachycardia, right, in hyper. Then STT changes. You will also see normocytic, normochromic anemia or macrocytic. Then there is also you'll do X-ray where we will see that there is cardiomegaly. Also there will be delayed ankle jerk. Now for the management, there is this drug named as L-thyroxine. Now this L-thyroxine is a very potent drug which is given in hypothyroidism. First of all, we give it as 50 to 100 micrograms, okay, daily on empty stomach. Then we increase the dose to 150. Then we take the maximum dose is 300. Now, if in case the patient forgets to take it, so he or she is advised to take the double amount the next day. Why so? Because T4 has a long life. Now, but in older patients, the drug dose is 50 micrograms per day. Now what you will see is that in 2 to 3 weeks the patient, he will become more active. There will be weight loss, there will be no swelling that will be seen, then there will be changes in hair, if hair effusion and skin. Then there is also one more thing. If the hypothyroid woman is becoming pregnant, so she has to increase the dose of thyroxine, because fetus is also dependent upon the maternal thyroid gland for the hormones. So yeah, so this completes hypothyroidism and hyperthyroidism.